Perfect. So, I will start with a brief introduction. Tatiana, you probably do not know that Michal Štofko is also co-author of the strategy concept of primary care in Slovakia, which was published in 2023. So that's actually one of his topics. He's not only state secretary responsible for all these qualitative criteria and health stuff, but he's also expert in this field. And also, he kick-started his career working for Sungest, which is a company which was financed in Slovakia through World Bank. So World Bank, the organization you are working now, actually helped his career in healthcare back in 2003, 2002? Something like that, yes. So, and the way I would like to have this discussion is that I will ask you questions regarding your expertise and experience. Then I will ask Michal to reflect on what is happening in Slovakia and what Slovak Ministry of Health plans to do in these areas, right? And I have three very simple questions. The first question is actually, how did you choose those individual elements in KPIs, in quality, in the bits that you actually wanted to be paid for?
Yeah, we aligned these indicators with the global health strategy. So the goals of the development of health system in Croatia was actually to improve medical outcomes, of course, to increase efficiency, increase quality, and to keep patients on primary level. In many ways, it is everywhere in the world recommended, so that if we keep a patient on a primary level, it's closer to his home. A family medicine doctor treats patient, and hospital treats disease. So we wanted all these indicators are basically in a way that a primary care doctor can manage all stable chronic diseases and to increase efficiency, decrease costs of health system.
Yes, I have two sub-questions. The first one, you said that you have a global strategy, which means like a Croatian global strategy for health?
Yeah, health strategy.
Yes, so something like URA's HSPA is getting ready, I guess. So that's the first point. And well, that's actually the most important bit. Michal, you helped to prepare the current version of primary care strategy. Is there any country that you actually got inspired by? And that's also maybe the question for Tatiana. If you actually looked into some other countries, because Slovakia tends to compare ourselves against Netherlands, we tend to compare ourselves against maybe Estonia. So the question is, then after you, like, what Croatia compares themselves against?
Well, this might be a question for you as well, as far we are both co-authors of the strategy.
Yes, true, but
I'm not sure if it's like a trick question, if I know or not. Well, we definitely didn't compare ourselves to Croatia. We usually look to the West, to countries like Czech Republic, and of course Denmark, Estonia, and Netherlands, but usually in terms of hospitals. I would like to follow up on your idea about the gatekeeping function of the primary care, or the physicians in primary care, or the GPs. This is something that we were lacking, actually. I believe that is one of the biggest issues that we currently have. So if you could elaborate maybe more on how you tried in Croatia to strengthen the gatekeeping function of the system, because this is something that we see we have basically turned around. We have more visits, and because we have a primary care level, then we have specialists, like an outpatient specialists, and then we have hospitals. Sorry, I'm taking over your job a little, but what our physicians do, they just send the patient, the GPs, they just send the patient to the specialist. Usually they don't do much of the gatekeeping as they should. So you know the ratios better than me, but it's usually something 60-40 or 70-30 is in the GP visits at the GP office and on the specialty level or specialized physicians level. In Slovakia, it's turned around. So we have 40% that stay. They keep the patients that stay in the GP level at the GP level, and the rest is going to the next level. So how were you able to, or do you have any strategy how to strengthen this? Because the only way I think we can do this is by strengthening competencies of the GPs, which is anyway not always taken very happily.
Yes, and yes, please, if you can kindly answer the question, because it also links to my second group of questions, is actually how did you persuade doctors to actually agree to the change? Because that's a massive issue. So, please.
Yeah, previously they were, maybe I will answer the second question. So it was 90%, that was for sure, whatever you do. And in our model, it was only 40% that was fixed, and you will get it regardless of how you work. And it was not easy to persuade them to switch from 90% certain to 40% certain income. But what we did the road trip, the director of Health Insurance Fund and me. Later he was a minister, and we did like 10 meetings all around Croatia. And we were sitting there like 6-7 hours answering all the questions of all the doctors, and they were all invited. So we basically saw 4,800 people in 3 months presenting our new model. And a key success factor was that this model and these elements were developed by doctors themselves, not like health insurance fund or ministry. We asked doctors, which ones do you want, which ones do you think would be effective? Then we gave them these tools for chronic disease management, because we have 50% of people who are diabetes, hypertension, COPD. So these three, asthma, COPD, diabetes, hypertension, 50% of everything that is going on in the system. 50% of cost in the world is these three chronic diseases. So we gave them tools, very simple tools, where they were managing their chronic patients, which are stable. And we incentivize if they don't refer. And we changed the model of referring so that the hospitals are giving internal referrals, and they don't serve as administrators of hospitals. So we unburdened them a little bit, and then we gave them more work on chronic diseases. And this was basically the most important part. Give them tools. And then we said, you can sign or you don't have to. You can keep capitation 90%. And when we gave them choice, they said, okay, then we will look what is useful for us.
Okay, I have 2 quick questions, if I may. How many GP associations you have in Croatia?
Around 3-4 main ones, which
Really?
has like 90%.
Because this is the biggest problem in Slovakia. Whatever you agree with the first one, the other 2 disagree.
We were not agreeing with them. We were agreeing with all of them. We made 10 meetings all around Croatia. We were sitting and answering questions that nobody answered for 20 years. And then in this communication with us, they started to trust us.
Okay, and I have a second question, and then Michael will also have questions. Apparently, we are like both of us questioning you. Did you offer them like, okay, you will switch from fixed income to variable income, but your income will grow over time? Did you sell it through like more money or not?
You saw this small, this in my presentation. It's like 10% increase in salary if they fulfill all KPIs, all QIs, all fee-for-services. If they are 5-star, if they have, so for example, KPIs were 7.5% of the salary. So if they achieve KPI, they have this 7.5. Then QI was 7.5. There's these 5 stars. We gave them these stamps, and then patients say, okay, my doctor is 5-star doctor. So there are some small things, like group practices. Your question was, what we were looking at. We were looking at Norway. We were looking at Denmark. So these are countries similar size as Croatia, but with great, I would always say Norway. Norway, primary healthcare, their response to COVID crisis, excellent. They were motivating doctors to, over time, ask patients and search for patients with cancer and things like that. So this is something that we really found very useful for us.
Norway is also basically the main country that we're looking at in terms of primary care reform when we did it, yes.
In fact, if I recall correctly, we also went to Norway to see...
You did, I did.
Yeah. We've been to Norway, and we were looking because their primary care is like probably the strongest in Europe.
And one more tiny question is that what would happen if a doctor did not fulfill the criteria? Would he receive lower income or 100%?
No, not 100%. They will receive this 40%, which is fixed. And then fee for service, which is around 30%. And then QIs, you know, if you decrease sick leave rate, they were working with patients to go less to sick leave, and they were increasing then 1% more. Then 1% if they prescribe antibiotics below the average of Croatia. And in 6 months, we had 8% less prescribed antibiotics in packages and 20% in finances because they were prescribing older antibiotics. And this is also, used for antimicrobial resistance.
I mean, I'm sorry for such very simple, straightforward questions because we've tried a lot and we failed a lot. And I'm just trying to figure out what was the key success factor that actually made you successful. If I may ask you, what is the shortage of GPs in Croatia?
Extremely, especially in primary care, and also their average age is like 58.
We are all a bit older. My question is, if I may take over a bit. Since this is a panel about equality in healthcare or equality in care, how did you increase your qualitative measures in time in terms of avoidable mortality and deaths of newborns or etc. Right? Like these are the measures that you're usually looking at if you want to see how the country is performing quality-wise. So did you see an increase in those indicators, or did you keep it flat? Just knew that the patients are taken care better, that you keep them at the GP level?
Well, for example, we introduced within this reform, we gave GPs possibility to introduce anticoagulant therapy, and in 5 years we saw less deaths regarding this. So you give them something and you incentivize if they, for example, introduce anticoagulant therapy to more patients, and then really in 5 years we saw less mortality of this population that was using anticoagulant therapy, because previously it was very complicated. They needed to go to hospital and find the doctor. We gave them more power, let's say, and they have these competencies. So, and we gave them tools, and we incentivize every good behavior. We didn't punish anything. We just gave them reward if they are doing things well. And we were putting one by one incentives for some things when we saw that some things either epidemiologically, organizationally needs to be corrected or improved.
In Slovakia, we have one specificity that I would like to ask whether you have something like that in Croatia as well. We can introduce whatever measure at the GP level, looking at the outcomes. They are usually biased based on our marginalized communities of Roma, since these are the people who pull down the measures, I mean the outcomes of the measures. Whatever we do, we always hit this wall, how you can incentivize this cohort of patients to take care better of themselves or to go to preventive whatever tests. And I believe you don't have something like this in Croatia. So you basically, if you introduce any kind of measures, it's basically something like helicopter measures where you see in a quick way the results, right?
Yes and no. We have, for example, very different from you, we have 60 inhabited islands. And these islands don't have doctors. So we incentivize nurses within the practice to actually make home visits, and we introduce telemedicine for early detection of stroke. We introduce telemedicine for ECG. Nurse putting this, and so there are some measures that you can even put like that. For example, incentivize doctors to reach out Roma population.
Yep.
And give them like 20% more if they achieve or something like that. So this is some.
I think Czech Republic tried to incentivize regional practice. We did this as well. It didn't work that much because the work is so much harder with those communities that it's basically nothing. I just got scared that Croatia is going to offer our physicians places at their islands to stay if they provide care.
Yeah, we have a shortage, so we will try. That's for sure. Key success factor, data. You have data in Slovakia. You have electronic health records. So to achieve all this, insurance companies must have this data of the doctors' population. So they don't need to have individualized data, but anonymized, aggregated data, specifically, for example, for this disease, for this doctor, they should have. So if you improve data, maybe you can also use something like that. But you already have it. You just need to use it better.
Yes, completely agree. We have last 3 minutes, and also we have Slido. So if you have any questions, just please feel free to open the Slido and ask us. And I have 2 more questions. Have you tried something like this also for hospital care?
We tried, but it's harder to penetrate their lobby, as you said.
And the hospitals in Croatia, they are not state-owned? Or?
State-owned and regionally owned.
Okay, good.
But we introduced five KPIs. For example, we introduced use of reserved antibiotic, and some organization like the ratio between non-medical and medical personnel as an incentive, so that they are incentivized to decrease non-medical personnel. To decrease non-medical personnel. And for this, for example, for this use of reserved antibiotic, which you are using only in special cases, we ended up in some hospitals that they are using more than 25% of reserved antibiotics on hospitalized patients. And when we published it, then these hospitals decreased it in 3 months, because in Europe, in Norway, this hospital would be locked, you know.
And if they didn't improve, what would happen?
They are not paid for this 5%.
That's it. Okay, good.
And also what we did, we put like DRG, so they are paying, they are charging by DRG, and if they don't fulfill 100%, even we are paying budget. We said 80% is for sure, whatever you do. But 20% you will get only if you achieve these services up to 100%. And if not, then other hospitals in regions who pass 100% will get your money.
Oh, that's very good.
So basically the answer to the question how to enforce quality in healthcare is to pay for it, right?
Payment, everything is payment.
All right, and we have last minute, maybe State Secretary can tell us what the Minister of Health plans to do regarding quality and pay for performance.
Well, there are a couple of measures that we're trying to introduce. What we are looking at is the new list of interventions in primary and specialty care, in outpatient care, which the issue what we have identified in our system is that the physicians are more incentivized to take care of the same patient more frequently than to take a new one and reduce the waiting times. If we're talking about outpatient care, basically we have huge waiting times in hospitals as well. So we are trying to shift the weights of the interventions towards the new patients instead of the regularly circled or rotated patients. If we're talking about more quality, then there are a couple of things that I think we should do. What we're doing is screenings, if we're talking about prevention, because I'm in charge of prevention at the ministry as well. Okay, so basically we're introducing 3 more screening programs. We are establishing a national screening center, which will have their own coordination in terms of incentivizing again patients or people to log into the screenings. And maybe the last thing what we are currently discussing is to find new incentives for physicians, for instance for obstetricians, to incentivize their patients to join the screenings as well.
And daily hospitals, we increased prices for daily hospitals and because they are more efficient. So this was also important part for hospitals.
Yes, so perfect. Thank you very much, Tatiana, Michal. Ladies and gentlemen, thank you for staying with us, and we will continue in a couple of minutes. Thank you.